Welcome back, everyone. As we jump into learning session two, which is the back half of the systematic approach to EMS. What we went over in the last session was kind of our initial scene size up, the scene management, and then our primary assessment. So, quick little recap. We need to keep our head on a swivel, make sure that we're safe as responders, so we can ensure the safety of, bystanders, our patient, our colleagues and such. And this is a continual process. The primary assessment really consists of the quick few things that are what we consider immediate life threats. So what are the things that, if not fixed, will kill the patient in a matter of minutes, right? If it's going to take us 20, 30 minutes to get to the hospital, we need to make sure if there's something that's going to kill them within that period of time, that we need to identify it and manage it. And so the primary assessment is checking those immediate life threats, figuring out whether it's high priority, low priority, and moving on, right? Um, Oftentimes for our higher acuity calls, we may get to the primary assessment, do a quick little secondary, and then we're going to do the rest in the truck later, right? So it can just depend on the acuity. So you're going to see the phrases primary assessment, secondary assessment throughout your reading. Again, that primary assessment, the immediate life threats, and then the secondary assessment is kind of the rest of the stuff, right? Once we've managed the immediate life threats, now what do we have going on? So that's the secondary assessment, and that's going to be what we cover tonight. It's that secondary assessment. Now you see in the systematic approach, it can go up, whether it's physical, or down if it's a medical call first. We go history, and then you go to the other, right? So you're actually doing both. You're getting a history and a physical. But if it's a trauma patient, you're doing the physical first. If it's a medical patient, you're getting the history first. But you still always get that history and physical. Then we'll move on to vital signs treatments. And you may think, well, I've come an EMT to treat patients, right? Why is it so far in this process? And that's simply because you don't know what to treat if you haven't fully assessed the patient, right? So you might mistreat them, you might treat the wrong thing, you could potentially cause harm with your treatments. And so before we ever intervene with the patient, we need to have a good, thorough understanding as to what we're doing. So we'll first talk about the physical or the trauma section of our secondary assessment. You're going to hear a phrase called DCAT BTLS. Um, it used to be when you do your psychomotors back in the way that it used to be structured before it was integrated into the class. Um, you'd even be potentially tested on DCAT BTLS. So it's still important to know. It's still something that we're checking. Um, and DCAT BTLS is more of a memory aid, right? And so when you're doing your physical assessment, when you're examining the patient, DCAT BTLS is one of those things that's going to be an aid that you're checking for as you do it, right? So it stands for a bunch of different things that we're checking for as we assess um, our trauma patient. So DCAP BTLS stands for deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, swelling. Typically, the way that you're going to go through your physical exam for a trauma patient, you're going to start up at the head, right? So after you've done the primary, you're going to start up at the head. You're checking for DCAP BTLS, right? And you're actually physically putting hands on the patient. You're palpating, right? You're pushing, you're feeling. So if we're up at the head, we're feeling, okay, does the skull feel secure? Is there any bleeding? Are there any skin flaps, right? Check the ears. Is there any cerebrospinal fluid coming out of the ears, the nose, the mouth, right? And that cerebrospinal fluid is a fluid that um, kind of the brain is bathed in, and then the spinal cord is bathed in. So if we see that leaking out, that means we have a pretty serious injury, right? You're going to check the eyes, the cheeks, right? The full head. And we're going to move down to the back of the neck, right? So we're going to feel the back of the neck. Do we feel any deformities? Do we have any crepitus, which is basically a crunching or grating feeling as we palpate the back of the patient's neck? Right, are there any penetrating injuries, right? Punctures, as you see in the P. Okay, now, let's check for a pulse again. It's always good to reassess. Okay, now we're going to check the neck, right? Is the trachea in the center, right? Because if it's pushed off to one side, that can be a pretty serious sign. That'd be called tracheal deviation. We're going to look at the veins in the neck, right? Are they flat or are they engorged, right? So if we get those veins on the side of the neck filling up, that would be called JVD, jugular venous distension. It can be a buildup and a backup, so that can be another serious sign. So now we're going to move down to the chest. Right? There's a lot of important organs in the chest. You get the heart, the lungs, super important, right? And you have some big blood vessels down there that if those get nicked, you'll bleed out really pretty quickly. So we want to assess the chest, right? Push on the chest, feel the chest. Does it feel stable, or do we feel some ribs moving around? We'll talk about later on what that can be like. We also want to listen to breath sounds, right? So we talked about it on our first lab day. Really, that turbulent flow of air is going to make noise, right? So if we listen to breath sounds, hopefully there are breath sounds, right? Because if we listen to the chest and we don't hear anything, well, that's a problem in its own right, right? But if we're listening and we hear wheezing or obstructed flow or something like that, that can be a real problem. If we hear fluid in the lungs, that can be an indication of buildup. So that's a problem. So now we're going to move down to the abdomen. We'll talk about that, but we're going to push on the abdomen and all the different places, make sure it's soft. We're also looking for, discoloration, bruises, all right, contusions. So then we're going to go down. We're going to check the pelvis. The way we check the pelvis is we first push in. We make sure it feels stable. And then if it's stable, we can push down, right? I wouldn't be surprised if as time changes on, that we don't do that pushing down part or maybe we'd just kind of assume that it's damaged. But for right now, that's how we do it. We push in. If it's stable, we can push down. And if at any point it's unstable, there's crepitus, we would stabilize it. So then we'll continue down the legs, right? We're checking for that decap BTLS. Is there any penetrations? Are there burns? Are there deformities, bruises, right? These sorts of things. And we're looking for any abnormalities, right? And if it's not an immediate life threat, at this point, we're just making note of it, right? Because if it's not an immediate life threat, we'll treat it later, right? Either when we're on the way to the hospital because we're down in the back of the ambulance, or that's getting done at the hospital. Okay, so we move down the extremities and now we're at the feet, right? Well, there's some systems that go between the body and then the end of the feet and also the end of the arms. And so what we'll do is we're going to check a thing called CSMs, um, circulation, sensation, motor. And basically what we're checking for is are all the systems between the center of the body and the end of this extremity, are they hooked up, right? So we're going to check for a pulse, right? Okay, are you getting blood from the body to the end of this extremity? Can you feel my touch, right? Are those sensory pathways intact? Motor function, can you wiggle your toes? Can you wiggle your feet, right? Are those systems in place? Not that necessarily we could, fix that, but it's important for us to know, okay, to what extent is there an injury, if any. So we've basically gone down the whole trunk, and now we can go up. Okay, now let's check the arms, right? So for the same thing, decap, BTLS, CSMs. Typically, a good rule of thumb when you're doing any sort of exam or assessing the patient, does the left look like the right? Right? Typically, one side is a mirror image of the other side more often than not, right? And so, especially in these trauma patients, well, if I think that something might be off or I'm not totally sure, um, we can compare the two, right? We'll do that pretty often for, say, a broken hip, right? Which is really a broken femur, but it's a topic for another day. But if I think you have an injury to one side, right? Okay, well, let me check this other side because maybe, um, maybe by seeing that difference, that can clue me into it. So the decap BTLS, understand what each of the things are, and make sure that you know it, right? So deformities are any time that part of the body looks abnormal, right? So it would normally look one way, but now it looks a different way. Imagine a broken bone sticking in the wrong direction. That's going to be a deformity, right? Contusions, you can think of that as bruising. There's bleeding under the skin. There's soft tissue damage underneath. Abrasion, so the actual top layer of the skin has been abraded. You think road rash, right? Punctures, penetrations. So anything that has punctured through the skin, so it hasn't just punctured the skin, but what else inside of that patient has been lacerated or punctured or damaged, right? Like how big was the thing? How deep did it go? What's under there? What did it nick? Burns, we'll go into more detail on burns later in the trauma, but there's different degrees of burns. Too much heat, not enough heat. So, extreme cold or cryogenics can cause burns as well. And they're all quite damaging. Tenderness, right? You could think of that as soreness. If I touch your belly and it hurts, it's tender, right? That's going to cause a painful response. You're not going to like that. Well, typically, if there's tenderness or pain somewhere, that's a sign that there's an injury, right? Lacerations, fancy term for cuts, right? So it can be as small as a paper cut. It can be as big as a chainsaw, right? Amputation. Likely not an actual amputation. You call it an amputation, but lacerations range in size is what I'm trying to get at. Swelling. Swelling, especially in trauma, is an indication of bleeding, right? Swelling can more commonly happen over time. You break something, you sprain something, right? Typically that swelling is going to happen over a period of time. But if you have a trauma patient, and then very quickly they start to develop swelling, uh, that's more likely an indication of internal bleeding, right? Because it takes a little bit longer for kind of the traditional swelling that we think of to develop. Um, so I kind of already start kind of previewed this, but we do our decap BTLS and we start up at the head, right? And so one of the things is while we're up at the head, we might as well redo our primary assessment, right? We went through it previously. Is it still working, right? Is the airway still patent? If not, we need to fix it. We need to make it patent. Breathing, are they breathing? Is it adequate? If not, we need to fix it, right? Circulation, you can check a pulse up there, right? Um, I'm reasonably confident that everybody here knows what kind of a normal body should look like. Does it look like that, right? Um, So you can visually inspect somebody and be like, okay, that seems pretty reasonable, but make sure you are actually putting your hands on them, because some things are just under the surface, right? By poking and prodding and feeling, you can feel if there's a broken bone under there or there's some tenderness, right? Because if you never actually touch them, that may not elicit that painful response from them. We want to make sure that we're checking mentation, right? And our first learning session, we went over AVPU and GCS. So here's another chance. Okay, are they alert? Are they unresponsive? What's their GCS? Pupils. Our first lab day, we went over checking pupils, right? And so the way it works is in the back of your eye, right, is where the image is developed, right? So your eyes are looking out, light goes in through the front of the eyes, and it hits the back of the eyeball. And that's where that image is developed. Right? To appropriately develop an image, you need a certain amount of light. Too much light, and it becomes overly washed out, right? Not enough light, and you're barely going to see it. And so what happens is your nervous system can control your pupils. They can dilate, which means they get bigger. They can constrict, which means they get smaller. And so your body controls this automatically, right? And so if you're in an area that does not have a lot of light, what will happen is your pupils will dilate, both of them will get bigger to let in more light, right? But now, let's say you go outside and there's a whole bunch of light. Well, what'll happen is those will constrict. They'll get smaller. The reason they get smaller is there's so much light that we only need to let in, a certain amount to develop that image. And so what can happen in head injuries, brain bleeds, and some other, medical neurologic conditions, but this system can become damaged or it can function inappropriately, right? And so what we can do is we can take our pen light, we can take the pen light from kind of the side of your head, not in front of your eyes. We turn it on and we slowly bring it into one of the eyes, right? And what we're looking for is both of those pupils should constrict. Right? You take the light away, you let them dilate back up again, you bring it over to the other side, you bring it over, you see for it to constrict, and you go away. So it can happen in some trauma cases. That process may not happen. You may get what's called a blown pupil, kind of the phrasing that we'll use in the field. And blown pupil means one of them's dilated. They may both be dilated. A pretty alarming condition is where one is dilated, one is not. Some folks live with unequal pupils. It's not terribly common, and typically, if they have it, they'd be able to tell it to you. But if it's an unresponsive trauma patient, you won't be able to know it. And so that's how and why we check the pupils. There's also some medical conditions that can cause them to be, overly constricted or dilated. We talked about redoing the primary. Is the airway still patent, right? If it's not, you need to fix it. The airway's not patent, we can't get any air into the lungs. That means we can't get any oxygen to the blood, which means we can't get it to the cells, which means we got a real problem, right? The patient's going to be in shock. Checking the neck, as we talked about, front and back. We're checking for that DCAT BTLS. That spinal motion restriction. If we think there could be an injury to the head, neck, or the back, we have to start that spinal motion restriction until we go through, a full clearance process. And so just kind of reaffirming that this is your chance to check the neck, feel for any step offs, which means are any of the vertebrae out of alignment, feel for any crepitus, or any of them crunchy or anything like that. It's typically too early to tell if the spinal motion restriction is still appropriate because there is a kind of a full clearance process, but just keep that in the back of your mind that we might be moving in that direction. Then the chest, right? IPA, inspect, palpate, auscultate. What does that mean? So visually inspect, look at the chest. What does it look like? Is it discolored? Does it look normal? Do things look out of place? Right? Just look at it. Palpate, fancy term for getting hands on, right? So palpate, I'm physically pushing and I'm touching, I'm feeling the ribs. Do they feel secure? I'm feeling the skin. Is it tender? Does it feel adequate or is there crepitus or something like that? Also we're going to go ahead, we're going to listen to the breath sounds. Are they normal? Are they abnormal? One of the worst things can be absent, right? So if I listen to the left side of your chest and it sounds normal, and I go over to the right side and I don't hear breath sounds, okay, we have a tension pneumothorax. Lay people to call that a collapsed lung, right? So now one of the lungs is collapsed. It can't inflate, so now only one side is able to inflate. That's a real problem. Is the chest rising and falling? Is it equal? Right? So this is one of the times where we compare the left to the right. Right? If one side is going up and one isn't, right, that's a problem. If one section of the chest is moving in opposite directions, that's a real problem. Does it feel stable, right? I'm checking the chest. The abdomen, I mentioned earlier about pushing on the abdomen. Um, for our purposes, we break the abdomen up into quadrants. So find basically the umbilical, the belly button, draw an up line and a left and right line, right? So you see on the chart here, RUQ, LUQ, RLQ, LLQ. Real simple, simple. Right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. Right? So we break them up into fours or quadrants. There's going to be upper and a lower and a right and a left. Anytime we're talking about right and left, we mean the patient's right or the patient's left. So if you look at somebody and you say, left, but it's your left, that's actually their right. So one of the things that you're going to have to become conscious of now is when we say right and left, we mean the patient's right or the patient's left. All right. Especially as you're starting out, that gets mixed up quite a bit, but put some effort in, work towards not doing that. And so what we're going to do is we're going to palpate all of the four quadrants. So typically we'll push our palm down and then we'll kind of roll it forward, right? And so we're feeling for any distension, any tenderness, right? We're checking for that decap BTLS. Is it pushed out? Is there bruising under there? Is there swelling, right? Is there discoloration? So the abdomen can hold a lot of blood. It can hold a lot of fluids. And there's a lot of organs down there, right? So as you see this picture and you see the right upper quadrant, left, right, you check these different quadrants, go ahead and look at all the different organs under there. There's hollow organs, solid organs. We'll get into the difference a little bit later on in the trauma section. But just understand we're checking these different quadrants because there's different organs and there's different things under there that we're assessing for. And that's why anatomy and physiology is so important, right? So going through those um, course videos in the Moodle, making sure you kind of understand what the different systems do, what the different functions are, where they are, how they work, is going to make you far more effective. So we've palpated all four quadrants. How does it feel? Does it feel like a normal abdomen? Does something feel off? Is it harder than normal? Is it causing pain? Is there, discoloration? So we're checking for all of these different things as we do our assessment because they can mean different things. You heard me talk earlier about going down to the legs and then up to the arms. So that's checking the extremities, right? So we've kind of checked the core, head down to the abdomen. There should be, okay, pelvis is listed here. But basically, once you check the abdomen, now you check the pelvis, right? So that's where you're pushing in, feeling if it's stable. If it's stable, then you can push down. So then you move on to extremities. Broadly, does the left look like the right? Right? Um, are they even? Is one shorter than the other? Is one discolored? Is one pointing in the wrong direction or something like that? Um, and then can we fix anything? We'll learn about different splinting techniques and bleeding control and all of this other stuff as we go through. Um, but if there's something you can fix, we will want to fix it. Typically, we fix the immediate life threats right when we find them. And then we fix the non-life threats later on. Once they're in the ambulance, things are kind of stabilized. We're a little bit more kind of sure as to our position. Then we're going to do some of these other interventions. When you get to the end of each extremity, left arm, left leg, right leg, you're checking your CSMs. Well, you're checking the patient's CSMs. Stands for circulation, sensory function, motor function. So in each extremity, we want to check a pulse, right? Are we getting a pulse of that extremity? If we're not, um, certainly they could be in cardiac arrest, but if all of the others have it, they're not. But it could be that one extremity, there's something impinging upon the artery. Capillary refill in each extremity, right? So blanching out that fingertip or that toe, pushing the blood out of the capillaries, letting go and seeing how quickly it comes back. If it's under 2 seconds, it's brisk. If it's more than 2 seconds, it's delayed, which can be a problem. Skin, we're looking CTC, color, temperature, condition. Is the color of the skin appropriate for the patient? Temperature, right? Normally you feel somebody, they feel, um, body temperature. If they have a fever, they feel warm. Or if they're, hypothermic or in shock, sometimes they'll feel cool, right? And then condition, right? Is it sweaty? Is it dry, right? Then sensory function. Typically, that's you touch the end of the extremity. Can you feel my touch? right? If they can't feel your touch, that's a sign that there's a problem. Motor function. Can you move your toes? Can you move your fingers? Right? If they're unable to move their extremities, that's another sign that there's a problem. It could be neurological, it could be a broken bone. We may not know, but if we don't do this full assessment, we're not going to be able to dig deeper and check it. We'll then want to check the back, right? And typically it's at this point where you've sent somebody to grab a moving device. And typically what you want to do with a number of people, right? You want somebody up at the head to manage spinal motion restriction. So typically the person at the head calls the shots, right? Because they're making sure that the patient's head stays in a anatomically neutral position, right? So they're going to hold the head and the neck. They're going to be keeping that alignment as the patient rolls. So they're typically the shot caller. So we're going to make sure we have enough people. We typically want to roll the patient onto the uninjured side. So if they have a broken left leg and the right leg is not broken, we want to roll them so their right leg is down on the ground, right? Because we don't want to roll the injured side and put their body weight on that extremity if we can help it. If all sides are all messed up, then hey, it's a judgment call. Do what you can. But typically we'll try to move them, roll them onto the uninjured side. So you roll them onto the uninjured side. We're checking the back, right? We're feeling all of the vertebra. We're checking all of the back of the chest, right, all of that. You can listen to breath sounds if you need. We're checking for a decap BTLS. We're looking for penetrations, injuries, all of the same things that we were looking for before. Can you treat anything? If there's a penetration in the chest, we'll talk about occlusive dressings, but you would put one of those on at this time. And figuring out, do we do it now? Do I do it later? How do I treat? And that's just going to depend on what the injury is, the overall condition of the patient, and if it's a life threat or not, as to when we're going to do it. Typically, after we've done our hands-on assessment, now it's time to consider patient movement and transportation. Right? We're not leaving patients in the field. We need to get them to definitive care. We need to get them to the hospital. And so we have, a number of tools in our toolbox. Which ones are the most appropriate, right? You see here on the left an ambulance. You see two EMS providers moving the stretcher. Right? That's what the patient's on once they're in the back of the truck. But we've got some other devices that can get patients from where they are to our stretcher, to the back of the truck. We've got a longboard, right, which is a big board with some holes that we can put some straps on, tie the patient to. We really don't use those anymore. There's a scoop stretcher, which is basically a longboard that can cut in half and it can slide under the patient, and then you can secure him to it. We'll use that as if a patient's stuck on their back, we need to carry them out to the stretcher. And then once we're on the stretcher, we would take it off, right? So we're only using the boards now to extricate the patient. Once they're on the stretcher, the board comes off, the scoop comes off, right? We also have a stair chair. Use that quite a bit. If somebody is up or down a flight of stairs and we need to get them out to the truck and they can tolerate sitting, yeah, we'll put them on the stair chair, carry them out, and then we can get them over to the stretcher. Blankets are huge. Blankets help get people lifted up, right, to a standing position. It helps wrap them into a burrito to keep the smells in. It helps get a blanket under and you can help carry them out. You can sheet transfer them from stretcher to stretcher. Blankets are going to be your best friend. Okay, so we've gone over the physical, the head to toe. We're poking, we're prodding, we're touching, we're feeling, we're looking, and we're looking for any injuries. We haven't yet talked about the treatments. If it's an immediate life threat, you do that. But all of the other stuff, like I said, we're saving. We'll quickly talk about treatments in the back half of our lecture tonight, but we're going to spend far more time under the cardiac, the medical, and the trauma section talking about our treatments. The other half of our history and physical, our secondary assessment, is the patient history. So the physical is where we're literally getting physical and hands-on. The history It's more kind of a cognitive event, right? It's us asking a bunch of questions, um, and we have some frameworks for that. So the history taking, like I said, is where we're asking a bunch of questions, and this is to as many people who will talk to us. So the patient themselves, any family. Sometimes you have family who are caregivers for patients, right? Parents, siblings, right? So many times family may have details about the patient, or at the very least, they can typically tell you the person's baseline. If we're getting a call for someone who maybe has Alzheimer's or some sort of cognitive decline, or has another sort form of altered mental status, well, family may know, okay, what is their normal? Or a stroke patient where the brain's not perfusing, and so they're not mentating quite right. The family or bystanders are likely to know, okay, what is their last node well? At 3:30, I talked to, Uncle Tony, and he was acting completely normal. And now it's 6:30 p.m. and he's slurring his speech. He's not able to make eye contact, and he can't form a sentence, something like that. So these friends and bystanders can provide all sorts of information. Also, healthcare providers, right? If they have a visiting nurse, a home health aide, if this is a transfer from an urgent care to a hospital, whatever it may be, you want to get as much information from as many people as you can, um, depending on the scene, right? So if you get a call to a guy at the bottom of the ladder who's unresponsive, and there's a neighbor over there. Hey, did you see the event? Yes, no. Hey, do you know this person? Oh yeah, I think he has diabetes. Okay, now we have something. So you can absolutely interview and ask people various questions. Another thing to consider is the patient a good historian? And so what that means is if I'm asking the patient questions, do they know the answers to these questions, right? If I say, do you have any medical history? And they're like, no, I don't know. And then the wife's like, yeah, they had a heart attack 2 years ago. He's a diabetic. He's, kind of epilepsy. He's got this, and this. Okay, the patient's not that great of a historian. Is it that they don't know? Is it that they can't answer because they're altered? Right, we may not yet know why they're a poor historian. But if somebody's a poor historian, we're going to lean more heavily onto the family, the friends, the bystanders, the healthcare providers, right? And then if you get there and the person, can answer all the questions, they know all the things, that they're actively engaged. Um, it's just going to change kind of how reliable you view their answers. Open versus closed questions. Right? So when you ask questions, you can ask an open-ended question, you can ask a closed-ended question. Both have their place. However, broadly, we want to make sure that we're asking open-ended questions. And the ended question is basically, how much room do you give for that person to answer? Let me give you two examples. How are you feeling right now? Is open-ended. The person has all the leeway in the world to answer that question. As opposed to, when did your chest pain start? Like, there's really only one way to answer that question. So open-ended questions, closed-ended questions, both are important. Typically try to make sure you're asking open-ended questions at every opportunity. Because if you're asking these closed-ended questions, there's a lot of information you may not get. And honestly, sometimes people will just talk and talk and talk and talk and talk, and you have a very specific question you need the answer to. Totally appropriate to ask closed-ended questions. If you're trying to get a very specific piece of information, closed-ended questions, completely appropriate. But broadly, we want to make sure that we're asking open-ended questions for the most part. Right? Then, as we are doing our history taking, we want to make sure that we follow a system, right? So a system upon a system, right? Because we're within the systematic approach. But especially as you're first learning all of this, there's a lot of different questions to ask. Um, and if you get stumped, if you get stuck, Having these frameworks are going to make it far easier to know what your next question is. And so that's where sample and OP QRST come in soon. Um, and it's at this point in the process where kind of the everything comes into play, right? With the call, you have your scene size up, you have your general impression, you've done your primary, maybe you've done a physical, whether depending, whether it's a trauma or a medical or not. Um, but your history is kind of where it comes into play. You'll hear a term called chief complaint. Chief complaint is something you're going to get on every single call, right? Um, and typically it's something that you need to figure out, right? So if you get a call for a person not feeling well and they are complaining of shakes, chills, fever, nausea, vomiting, and dizziness, right? You have to kind of pick one of those things to call the chief complaint. Sometimes the chief complaint is a symptom. Sometimes the chief complaint is an event, right? So the chief complaint may be a fall. The chief complaint may be chest pain. The chief complaint may be dizziness. It may be weakness. They can frequently be vague, right? That general malaise patient we talked about earlier, it's like just a bunch of symptoms of not feeling well. But sometimes it can be really clear and concise of, fall from a 20-foot ladder, right? Um, so the chief complaint, oftentimes it can hopefully be pretty clear, but the cases when it's vague, just do your best. I'll typically go with the event, or I'll try to go with the most severe complaint, right? So if it's a motor vehicle accident, sometimes I'll go with that. If kind of their complaints are, well, I kind of have some um, bruising and I'm nauseous, right? I may go with the motor vehicle complaint. If I get there and it's a very obvious, um, heart attack potentially, I'll probably say, chest pain or a STEMI or something like that. So the chief complaint, as you get a little more comfortable being an EMT and an EMS provider, those can get a little easier to suss out. Sometimes you get there and you're just like, I really don't know which one to pick. Um, Use your best judgment. As we're going through our medical history, there's two things that we want to get, PMH and the HPI. So PMH is the past medical history. So this is everything in the patient's past. This is that they're a diabetic. This is that they had a stent placed 2 years ago. This is that they had a kidney transplant or whatever it may be. So this is all of the stuff in the past. Many times it may be irrelevant, but sometimes it's critical, right? If you get there and they're complaining of chest pain and difficulty breathing, and they had, a heart attack a year ago, hey, okay, this is pretty critical. If they had their tonsils out at 13 and they're now 80 years old and they're complaining of GI bleeding, the tonsillectomy is irrelevant, right? Or likely irrelevant, right? Um, And so your past medical history just kind of depends on the current presentation, the current, set of symptoms, and what that past medical history is. Still get it. Um, it can still be very important, but just recognize that. Then we have HPI, History of Present Illness. So this is their medical history as it relates to their chief complaint. So it's far more direct, right? So for example, this is I'm having chest pain. It started an hour ago. I'm having difficulty breathing. That started half an hour ago. I'm sweating. That started half an hour ago. Right? So that's your history of present illness. What are the signs and symptoms? What are the conditions? What are the complaints that are isolated to, really the reason that you called 911 today? Not the fact that you stubbed your toe 10 years ago. Right? We're getting both, but they're in different categories, if you see what I'm saying. Another thing to look out and check for are medical identification devices, jewelry, so a bracelet, a necklace. Um, I've seen a couple people have tattoos. I necessarily don't look for tattoos. Um, Wallets, we typically don't go through wallets unless the person's unconscious and we're trying to find out, who this person is. But they may have cards with, um, meds or allergies or poignant medical conditions. These people can put whatever they want on here. File of life is typically something you're going to see um, stuck on people's fridges. So File Life is a company that makes these pieces of paper and these little kind of things that stick on your fridge. Um, and people can put information about themselves. Oftentimes, people will put medical information on the fridge, or I've had a really good time finding it on like countertops, kitchen tables, countertops. Oftentimes, especially if people are older and quite a bit sicker, they're going to have all of their files and folders and such um, in one of these two locations. Sam asks, I know cell phones have spots to do medical IDs info now. Is that something we would check? Yes, I'll be honest. I have it set up on my phone. I always forget to check. Um, and so it's just kind of one of those things of the phone ICE in case of emergency is great. Um, if we had to call somebody, get some information last in a while, that sort of a thing. Um, I definitely recommend people have it filled out. If you get to the hospital and you're a complete John Doe, Jane Doe, um, they're definitely likely to use it. Whereas in the ambulance, many times we're treating the signs and symptoms that we see, um, right? Because if you're a diabetic, I have a thing that can check that. If you're not breathing, I have a thing that can find and fix that. And so, um, I'm just kind of recognizing that. Where it is really helpful is bringing it to the hospital, right? So the hospital is going to need that information quite a bit more than we might in some cases. And so recognizing that if you're on scene and somebody's a John Doe, yeah, bring their phone with them because as to your point, okay, it might have information on there. Bring their wallet with them, bring the jewelry, right? So we're on the scene, we're the eyes and ears for the hospital who's going to be this person's definitive care. And so if there's information that we can gather for them to make their care more effective, um, it's prudent for us to do so. So the sample and OPQRST. So you're doing one sample history for the patient, and then you might do multiple OPQRSTs. So let's walk through the sample history. So sample history stands for signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, and events leading up to present illness or injury. You should memorize sample history. So the S for each sign and symptom will do an OPQRST. I'll do the next slide. So if they have chest pain and difficulty breathing, we're going to do an OPQRST for the chest pain and also one for the difficulty breathing. The patient's only going to have one set of allergies. So we want to find out what medications they're allergic to, any environmental things that they're allergic to, foods, all of those. Medications. I want to know what medications you take, whether they're over the counter, prescribed, or recreational. I also want to know what medications you're prescribed and do not take, because that tells me your medical condition and that it's also untreated, right? Another thing you'll see, and this will come in more into play in like overdoses, but when prescriptions are dispensed, it puts the like on the pill bottle, the label is going to have the doctor that prescribed it, the pharmacy, so you can get more information that way. But the label is going to have the date it was filled, the dose, and how many, right? So if this was filled 2 days ago and 30 pills were put in this bottle and there's now two pills, hey, that tells me something. If this bottle was filled 30 days ago, it was filled 30 pills and there's 25 pills in the bottle, hey, that tells me something too. So anytime somebody says, "Do you want to see my pill bottles?" I typically say yes, right? Because it allows me to see, are they current? Are they taking them on time? I can write down the name of the medications. I can get the doctor's information, that sort of a deal. Pertinent past medical history. Okay, do you have diabetes? Do you have epilepsy? Do you have, right, any of these other things? Um, then I compare that with the medications. Are you taking them? Are you not taking them, right? That clues me in. Less oral intake. What's the last time you ate or drank? What was it? Especially in the summer if they're feeling weak, dizzy, woozy. Okay, if you've been eating and drinking normally, right? That can be super helpful. Then events leading up to it. In the winter, we'll see quite a bit. Somebody goes out, they shovel snow, they come back, they have chest pain, they go into cardiac arrest. Okay, what were you doing up to this point, right? That can be pretty important for us as well. OPQRST. So you're doing an OPQRST for each sign or symptom, right? So if they have chest pain, that's an OPQRST. If they have nausea, that can be an OPQRST, right? Again, this is also a thing you'll need to memorize. So OPQRST stands for onset, provocation, quality, region of radiation, severity, and time history. All right. Onset of the event. What were you doing when it started? Right? Provocation or palliation. What makes it better? What makes it worse? If you wake up in the morning and your arm hurts, well, wake up in the afternoon. Right? Um, that can help clue us in, right? Quality of pain. Can you describe it? What does it feel like? Is it a crushing pain? Is it a tearing pain? Is it a stabbing pain? Um, and give us a little more detail. Region radiation, where is it? Physically, where is it on your body? Does it radiate anywhere? Does it go somewhere? Oh, I have chest pain, but it shoots up to my jaw. Uh-oh, that's not good. Right? So where is it, and does it radiate to another part of the body? Severity, on a scale of 1 to 10, how bad is it? So on a scale of 1 to 10, 0 being no discomfort at all, 10 being the most unbearable discomfort, how would you rate this? Right? And let the patient, in their own words, rate how severe it is. Then time and history. How long has it been going on? Right? So the onset, what were you doing? And then time, how long has this been going on? Has it been consistent? Has it been intermittent, meaning it's coming and it's going, it's coming and going, right? And so as you go through um, your OPQRST, this is where you're going to want to be asking a lot of these open-ended questions, sussing things out, getting details, and so on. Do you guys have any questions up to this point? I think we'll okay. We'll do the assessment with age, and then we'll pause here. We got one slide left. Um, assessment with age. Just recognize that patients are going to be different points in the life at different ages, right? I don't want to go up to a kid and say, um, "When did you develop this epistaxis?" Right? I'm going to freak the kid out. So when it comes to kids, use simple language. Do you have a tummy ache? When did that happen, right? Now you don't want to do that with the elderly person. Oh, when did the tummy ache, right? So you want to use age appropriate questioning and language. And you also want to make sure that you're avoiding medical jargon. Um, you might feel like it's impressive, but it's not. Use the language that people are going to understand, right? Use the medical jargon for the doctors and the nurses and other EMTs. Use plain, simple language with our patients. Our pediatric patients include parents and caregivers, right? They're likely to know the patient's baseline and what their normal is. Our pediatric patients, as you're doing stuff, explain first. So if you're going to put a blood pressure cuff on, check their blood pressure. Tell them, hey, I'm going to put this cuff on your arm. It's just going to squeeze a little. It won't hurt. Um, let them know what's happening, right? If there's an area of the child that's painful or in pain, I should say, check that last, right? Because once you cause pain, they're not going to want to engage with the assessment anymore. So if you know they have stomach pains, check everything else and then check that area last, right? Geriatrics, typically you want to be on their level, right? So you can sit down next to them, you can kneel, try to be able to make eye contact. right? They can be pretty sensitive to being talked down to, right? They've spent their whole life as an adult, and now they need other people to care for them, and that's a very sensitive position to be. You want to make sure that you're speaking clearly without yelling. Sometimes, yes, our elderly patients are hard of hearing, um, but resort to raising your voice later, right? Don't just assume because they're old, I have to increase my voice. Many times they can hear just fine. And if our geriatric patients have caregivers or other healthcare providers, include them, right? Many times geriatric patients may not give you the full story. They may not tell you everything because they're, afraid of being removed from their house, putting into a home or something like that. So getting down to their level, articulating clearly, avoid jargon, and then include the caregivers as you care for these patients. We started getting a little bit of practice our first lab day with some vital signs, doing blood pressures, checking for a pulse, pupils. All right, and I kind of started to go over what we're checking for, but also why it's important. So, as we gather all of this information throughout our systematic approach and our patient assessment, we're taking all of this data and we're using it to paint a picture, right? And we're adding the training that we get in this class and any other classes, and then our own experiences. That's really what's going to guide us to um, the interventions that we feel this patient will need in their diagnosis. Vital signs, according to the Merriam-Webster dictionary, are measurable variables considered to indicate the general state or condition of something. And so for us, it's the patient, right? So it's things that we can measure. They're variables, which means they can change. And then we're using this information to indicate the state of the systems in the patient and the patient's broader condition. These vital signs are data gathered and integrated to further inform your assessment and diagnosis. Right? So we've done our physical assessment, we've done our history taking, and so now we're going to get some vital signs, right? So they're going to help push us in a direction. They might kind of rule things out, which would be, working on your differential diagnosis. And so typically, we're going to get multiple sets of vitals. Our first set of vitals is kind of the soonest in the patient care, and we're calling that our baseline set of vitals. But what that does for us is it gives us a jumping off point. So by doing an initial set of vitals, by getting that baseline set of vitals, as we treat the patient, as we interact with the patient, they're going to do one of three things. They'll get better, they'll get worse, or they'll stay the same. Right? So we know that it's going to be one of these three things. By getting a initial set of baseline vitals, that allows us to trend the patient in one of those, three directions throughout our patient care, right? Because if you get the patient, you do a quick assessment, you do some treatments, you get them to the hospital, and they're like, okay, did the thing work? Oh, I don't know. What do you mean, right? We need to have something to base this off of. So the subsequent vitals that we take after the baseline are repeat sets of vitals. These are what we use to establish the trend, right? Are they getting better? Are they staying the same? Are they getting the worse? So one of the first vitals, one of the easier ones to get is a pulse. And so the pulse is measuring the heart rate. So how many times in a minute is the patient's heart beating, right? And this is the pressure you feel over an artery for each contraction of the heart. Right? This is one of those things you just have to get good at. Practice on yourself, practice on your partner, practice on your pet. Like, you know what I mean? Well, I know my dog, you pick her up, and if you start walking towards the bathtub, you can just feel da 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 da, right? So get comfortable feeling for pulses. Um, so you're feeling that pressure wave over the artery each time the heart contracts. And so one of the things to recognize is, especially if you're kind of still developing your ability to confidently check a pulse, you're trying to do this, you have to be in the right spot. Let's say you're not quite feeling it, you're already a little anxious, you might just, out of reaction, like push harder. And so if you push so hard that you occlude the artery, you're not going to feel anything. Um, and so just recognize that if you're having a hard time feeling a pulse, lighten up your touch. You're likely pushing too hard. We want to assess the rhythm and the quality of the pulse. So the rate, rhythm, quality. Rate, rhythm, quality. Rate, how many times in a minute is it beating? What is the rhythm? Is it regular, right? Are there regular intervals between this? Or is it just kind of beat, beat, pause, beat, pause, right? Is it regular or irregular? The common places we're assessing for pulse, the wrist, the neck, the feet, right? All of these different places. And especially as you check CSMs, you can check the feet, you can check the wrist, and then a good carotid pulse will going to be one of the first things you check if they're kind of unconscious. Typically, if the person's alert oriented, I'm not checking a carotid, which is the one in the neck. I'm going for their wrist, right? Because if they're awake, I know they have a pulse, right? And I don't want to freak them out by going in right for the neck shot, right? So I'll go in, feel for the wrist, and it's the thumb side, right? Um, so when you feel for the radial pulse, the artery is going to be on the side with the thumb, and it's going to be on the palm side, right? So if you think of the anatomically neutral position, it's going to be anterior and it's going to be lateral. We started talking a little bit about medical terminology, right? So hopefully you've had a chance to watch those videos at this point. But Brady means slow, tachy means fast, cardia, heart. So bradycardia is a slow heart rate. Tachycardia is a fast heart rate. So you see over here, heart rate by age. And so kind of that 60 to 100, 70 to 100 is a normal pulse for an adult, and then it gets a little bit higher as you get younger. As you go through vitals, it's important to just know what is normal, right? It's just a thing you'll have to learn. So make flashcards, take notes, figure out what normal vital signs are for patients. So there's your pulse. Respiratory rate, how many breaths in a minute, right? We're again looking for rate, rhythm, quality, right? So how many times in 1 minute are you breathing? We talked about it over the first lab day, but you could count for 1 full minute, right? And that would certainly give you a very accurate result. Another thing you could do is you could count for 30 seconds. So if you have a watch with a second hand or a digital clock that counts the seconds, you could count for 30 seconds, double it. I would say most people, what they do is they'll count for 15 seconds. And because that's a quarter of a minute, they times it by four. But really, what you do is if you count for 15 seconds, double it and then double it again. To me, that's just doubling a number is easier in my head. So if I count for 15 seconds, I double it and then I double that number. I've got, my times in a minute. Another thing you could do, it's going to give you a pretty low resolution number, but if you count for 6 seconds, and then just add a zero. And so count for 6 seconds, add a zero. That's how many times in a minute. I will also say, as you're taking vital signs, low, normal, high, right? Especially at the beginning, low, normal, high. Learn what a normal heart rate is, learn what a normal respiratory rate, learn what a normal blood, like learn what the normals are. And that very first kind of, I'm at the bedside, I'm checking the pulse. Oh man, this feels faster than I'm used to. Oh yeah, it's fast, right? They're tachycardic. Man, this feels, I'm having a hard time. It's kind of really slow. All right, they're bradycardic. So figure out what that low, normal, high is, and that's going to help clue you in, especially at the beginning. So our respiratory rate, breaths per minute, rate, rhythm, quality. Slow, normal, fast. Rhythm, regular or irregular, right? Is there kind of the same amount of time between each breath? Were there a few and then a pause and then a few and a pause? quality? Are they big, deep breaths? Are they shallow breaths? Does it feel like the person can't catch their breath, right? Is it labored? It's taking a lot of effort, right? These are all super important things to check. Noisy. Listen to the breath sound. And hey, sometimes you can hear it at the door, right? Sometimes you walk into a room and you're like, is that the guy's breathing? Ooh, right? Um, because as we talked about, anytime there's an impedance of airflow, you get this turbulent flow, just like a whistle, you're going to hear a noise. And so noisy breath sounds indicate there's some sort of obstruction or change in the flow. 12 to 20 is a normal adult respiratory rate, and then it gets higher the younger they get, right? And so another reason it's important to know what normal is, especially respiratory rate. Let's say um, you get a patient and you're so used to dealing with adult patients, the 12 to 20. Now you get a kid, they're breathing away at 30 times a minute. You're like, oh no, this is fast, they're in trouble. Ba, 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 ba. You think something's bad, but oh, that's just baseline for them because they have a higher demand for oxygen at baseline. And so it's important to recognize what normal is. That way, if something is abnormal, you know it's a problem. And also you don't get tricked by what is normal that may be based on a different age range. Pulse oximetry. This is one of my more favorite slides in this PowerPoint because um, even people who've been doing this for a while don't always know what we're about to cover here. So the pulse oximetry we talked about during our first lab day. We talked about how the pulse oximeter works, that it does rely on blood flow. And so a normal pulse oximetry reading is greater than or equal to 95%. If you get a reading of 90 to 94%, we consider that mild hypoxia. Hypo, low, oxia, oxygen, low oxygen saturation, right? And there is such a thing as hyperoxia. Moving on, moderate hypoxia, 75 to 89%. Boy, you really don't want to see that. That's not good. And then what you really, really, really don't want to see would be that severe hypoxia, less than 75%. You got some trouble on your hands if the number starts with a seven. And so one of the interesting things is, the pulse oximeters we practice with in class, they're cheapo. They're $10 Amazon pulse oxes. It's just to, you know, put your hands on, practice putting your finger in it and seeing the number. The ones we carry on the trucks are, at least the ones attached to the monitor, are significantly more expensive, and they've got some more features. We also did talk about how the pulse oximeter can lie to you if a person has poor perfusion, or poor circulation. And so, one of the cool features about the fancy pulse oximeters, is they'll give you what's called a pleth wave. So you see this graphic on the right. You see these different wave forms. And so when you use the cardiac monitor and you put it on, and sometimes you have to change a setting in the monitor to show you the SpO2 wave, um, when you get to your service, put the pulse ox on, see if you can see the pleth wave. If not, ask them to show you. But when you put the pulse oximeter on, it generates this pleth wave. And now the first one is a normal pleth wave. So you see this clean peak, this clean valley, this clean peak, this clean valley, this clean peak. And that's actually going to match if you look up on their ECG. So if you put them on the cardiac monitor, so those electrodes that you put them on, those should line up, right? Because it's kind of the same thing. It can also pick up an irregular heartbeat. So you notice the middle ones there, are showing an irregular heartbeat. But really, what I want to call out to you is that last one, right? So the most important is recognize the difference between the top one and the bottom one. So that top, basically a sine wave, it's nice and clean. That's telling you you're getting a good reading from the pulse oximeter, right? Like the number it's giving you, you're pretty sure that you can trust it because pulse oximeters frequently will lie to you. Very frequently will lie to you. And not knowing the difference in these waveforms is going to go a long way for you not getting tricked. So look at this bottom waveform. You see how it's kind of muted and kind of lame, right? It's a lot shallower, it's finer, it's just not as impressive as that top line. So if you put somebody on the pulse oximeter and let's say it's giving you a low number, let's say it's saying 85, right? You might want to go like, oh my God, they're hypoxic, blah, 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 blah. But if you look at this waveform and it looks lame like this, diagnose the pulse oximeter first, right? Is it seated well on the fingers? They're nail polished. They have good perfusion. Spend some time, and just as you get more comfortable with pulse oximeters, you'll get a little bit better at managing these things. But if you get a low reading and then the pulse oximetry wave is low and muted, first spend some time, make sure the pulse oximeter is good. There's not too much light. It's seated right. And then if you're able to now get a good normal waveform, if that number shoots back up, great. But if you're getting that good normal waveform and the number is still low, okay, they're really truly hypoxic. Now, if they have this weak signal and you can't get it better and it's showing hypoxic, treat them as if they're hypoxic, right? Um, Chances are they might need it, but that's just a tool in your toolbox to help prevent yourself from getting duped. So the pulse oximetry measures the amount of oxygen bound to the hemoglobin. Um, the your cells, right? So the cells in your body do functions, and those functions keep you alive. Those cells need resources. They need oxygen, they need sugar. With that, they make energy. Um, and then there's a byproduct of the cells making energy. And the byproduct for us is CO2, carbon dioxide, right? C for carbon, O for oxygen, 2 for carbon dioxide. CO2 or carbon dioxide is a byproduct of cellular metabolism, right? Uh, Aerobic um, cellular metabolism. And so what happens is when you take a breath in, the oxygen goes from outside to the blood, goes out to the cells, they do their thing, they make energy, they make their byproduct, which is CO2. That CO2 goes back to the lungs and then it gets exhaled, it gets breathed out. Well, one of the things that we can do is we can put you on a nasal cannula that we can also hook into our monitor, and the monitor has a little pump and it pulls, right? And so when you exhale, it pulls into this monitor and it will actually graph out the CO2 reading. And so if you put your patient on end tidal monitoring, um, it will graph out the CO2 that they exhale. So it can tell you a few things. If you think you have a patient who's septic, right? So they have hypoperfusion, and the cells are not performing as well as they would otherwise. You might get reduced end tidal. So this could clue you into a patient who has sepsis. The other thing that this can clue you into is um, constrictions of the airway, right? And so by putting somebody on end tidal monitoring, I can actually see, are they cleanly exhaling breaths? Am I getting an appropriate amount of end tidal CO2? And so a normal reading would be 35 to 45 millimeters of mercury. Okay, so it's a pressure. And this end tidal CO2 is measuring the exhaled carbon dioxide, which is a byproduct of cellular metabolism. So on the right here, you see a little graphic, and that's a normal capnograph. You don't need to learn the phases. Just recognize that a normal capnograph has a space line, it goes up, and then you actually see as it kind of moves towards the right, it actually peaks up. So it's measuring at this top point up here, and then it comes back in and stops. Later on, we'll cover what some abnormal capnography looks like and what that means. But for right now, just recognize that we can measure the byproduct of cellular metabolism. And anytime you have a patient who has difficulty breathing, I would advocate you put them on end-tidal, right? The other thing that I like about this is, it's really easy to get distracted in the back of the ambulance and have your attention pulled over here, have it pulled over there, whatever. If you put your patient on end-tidal and they stop breathing, the box will beep at you. And uh, as cheeky as it sounds, if you have a lot of things going on, and you're just working through a bunch of stuff, and you have a patient who, is maybe not doing so well, maybe they have some respiratory stuff. If you put them on end tidal, you don't even have to flow oxygen. Um, it'll give you an accurate respiratory rate, which is huge. And if they go into apnea, um, it'll make one heck of a ruckus. And so this is kind of a nice safety net that I advocate people use, really in a respiratory column. Blood pressures. We did those the first day. You can see a little chart here of normal blood pressures. So the top number is the systolic, so that's the pressure in your vasculature when the heart's actively squeezing. And then the diastolic's the bottom number. That's the pressure when your heart is at rest, right? So blood pressure is the pressure of circulating blood against the walls of your blood vessels. Um, there is a thing called a MAP, a mean arterial pressure. And mean arterial pressure is basically kind of average pressure. It's really good to know, A, how to do this and what it is. So the brain, to be able to perfuse, needs a map of 60 to 65 millimeters of mercury. Anything lower and you're going to have problems. And so one of the things we want to do is okay, what's the patient's map? Is their brain perfusing, right? Because if they're hypotensive, hypo, low, tensive, pressure, hypo, right? There's low blood pressure. That's going to be a real problem. And so we can calculate a map by taking the systolic blood pressure plus the diastolic pressure plus the diastolic blood pressure again, divide that number by three, and you're going to have your map. I'm not a mathematician. I've tried figuring out why they do the diastolic twice. I, I think something because the vessels are round or something like that. Honestly, I don't know. But that is the formula to get the map. If you have your patient on the cardiac monitor, the map is typically in parentheses. So you'll see 120 over 80, and then you'll see a map of, whatever that number is. So, 120 plus 80 is 200, plus another 80 is 280. So 280 divided by 3. So that would be a map of 93, right? So, if you see on the monitor, it says 120 over 80, and then you see the number 93 in parentheses, it's done that calculation for you. That's the map. Another neat thing that you can do is get a blood pressure over palp. And so when you put the blood pressure cuff on, you pump it all the way up, and let's say the systolic blood pressure is 120. If you pump that cuff up to 130, they won't have a pulse in that arm anymore, right? Because you're exerting more pressure, you've occluded that artery. And so let's say you're having one heck of a time getting a blood pressure. You can't hear anything no matter what you do. Well, one of the things you could do is you can feel for a pulse in that extremity, put the blood pressure cuff on, pump it up. And when that pulse goes away, that's your systolic blood pressure, right? And so the way you would document that is let's say it's 120. So you document that as 120 slash and then a P. And so in your documentation, that would indicate the systolic blood pressure is 120, and you found that through palpation, right? And so that's just kind of a backup method. If you can't auscultate a blood pressure, get one over palp, right? You don't want to just not do it, but if you're having a hard time, kind of the standard way, use the backup way of doing it over palp. Blood glucose. I don't have the syllabus in front of me. I believe we're doing that this weekend. Um, Nobody's favorite. Um, but sugar is really important. We'll talk about how your cells need it. We'll talk about how your brain needs it and your body needs sugar. And so one of the things that we check as a vital sign is blood sugar, right? So typically what we'll do anytime somebody has altered mental status where they're a diabetic, we'll check a blood sugar. And so we'll get to practice that. Hypoglycemia, hypo, low, glycemia, sugar. Um, Low blood sugar is below 60 or 70. Normal is about 70 to 120. And then high blood sugar, hyperglycemia, is 2 to 300 um, of a reading. And so we'll talk about the different things and kind of what this means as we go through the medical chapter and such. But recognize one of the things we'll do is check blood sugars, and this will be fairly important, and we'll get plenty of practice on doing it. Skin, massive organ, right? And so the skin uses a lot of resources. And one of the things that will happen is, especially in trauma patients or severely sick patients, the body will try to conserve resources. And so it may shunt the skin or deprive it of some of the resources. And so you can see that. And so by checking skin signs, color, temperature, condition, you can actually get a fair bit of information um, as to what's going on underneath, right? What's going on inside our patient. Temperature is one of the things. So normal temperature, 97 to 99 Fahrenheit. Hypothermia would be a low temperature. Hyperthermia would be a high temperature. They're both bad for different reasons, right? So there's a reason there's normal range. Condition, normal, abnormal, right? Pink, warm, dry is kind of the kind of normal skin condition, right? Is it appropriately colored? Is it warm appropriately? And is the skin dry, right? Abnormal would be pale skin, cool to touch, clammy skin. Diaphoretic would be sweating, right? So these skin signs, we want to assess for these. We want to document for these because they can mean various things as we learn more. Pupils, which we talked about. So we're looking for a few things. Size, are they small? Are they large? The pen lights have a little scale on the side, and those circles are the different sizes. They have the size, they're in millimeters. We're also looking for equality. We want the left and the right to be matched, right? We want the sizes to be matched. We want the speed at which they dilate and constrict to be matched. And if these are abnormal, there's something going on. Um, some patients at baseline have different sized pupils. So this bottom picture down here, you'll notice that the patient's left eye is more dilated than the patient's right. And so that's something to be aware of. Some patients have that at baseline. That can be also a result of a traumatic injury. So it just kind of depends on the patient that's in front of us. When you're checking pupils, if they're normal, you typically put in your report PERLA, which stands for pupils are equal, round, reactive to light, and accommodation, which means the things are working normally. When you put light, they get smaller. When you take the light away, they get larger. They're not too slow, right? Because if you put the light on it, it takes a while. We call that sluggish, right? So if they're like taking their time to get constricted, that could be a problem. And so the pearl is kind of the normal baseline for checking pupils. So after all that, we've gone and done our scene size up. We've done our primary assessment. We've done our history, our physical. We've gotten vitals. Oh boy, it's been a while. And now we can do our treatments. Right? Because you can't do or you shouldn't do treatments if you don't actually know what's going on. Like, don't just do things to do things. Do an intervention, have an understanding of what the intervention is, how it's supposed to work, and what you expect out of it, right? And so it's at this point that we identify, select, and perform the appropriate treatments and interventions, right? And now we also have to transport to the most appropriate facility, right? So we follow this whole systematic approach to get us to where we need to be. And now we can start doing our interventions, right? So now that we've done all of this, we've started to treat the patient, we're transporting to the hospital. Now what? Well, now it's time to do some of it again, right? This is our continuous reassessment. And so this is where, because we did a baseline set of vitals, we can establish our trends, right? So we're going to do vitals again. Is the patient getting better? Are they getting worse? Are they staying the same, right? If there were immediate life threats and we managed them, are our interventions still working? Do they need to be peaked or tweaked? Do we need to make changes? Um, it could be a chest trauma, and I listened to breath sounds and they were good. But now, 10 minutes into it, they're having a hard time breathing. I listen, and uh-oh, one of their lungs is collapsed. They've developed a tension pneumo. That's an immediate life threat. So it could be that, hey, I checked it 10 minutes ago, it was good, but now they've deteriorated, right? Um, Repeat your key elements of your assessment, your ABCs continuously, right? We're checking vitals as need. If we've done an intervention, check it. If I found that you had a broken arm and I splinted that arm to make it more comfortable for you and reduce any further injury, how's that splint doing? Is it still working? Actually, it kind of slipped. It's, not quite working. Okay, well, let me recheck CSMs. Let me fix the splint, right? So I can't really tell you exactly what to check or what to reassess, but use your head, right? Like if you've done something, um, recheck it, right? If something is likely to have changed, recheck it, right? So this is going to be patient by patient, call by call, but figure out, okay, what's the likely thing to change? Recheck it, reassess it. How and when? With respect to vital signs, you can always recheck it sooner, but you never want to check it too late. So what I mean by that is if the patient is unstable, so that's that sick, not sick, right? If they're sick, they're unstable, you want to be reassessing every 5 minutes. This can be a very dynamic situation. You don't want to be asleep at the wheel for these patients. So our unstable patients, we're reassessing at least every 5 minutes. You can reassess more often than that, where more realistically what it's going to be is you're going to have kind of a continuous reassessment. So I check this. Now I come back and I check this. Now I come back and I check this. Now I do vitals. I know it's been 5 minutes. So now, okay, is this still working? And honestly, a lot of times it's just a conversation, right? I put them on the monitor. I set it to 5 or 10 minutes as kind of a recycle. And I'm a yapper, as you've probably figured out. So I can talk to anyone really about anything. I'll find common ground with anybody. And so I'll spend 10, 15 minutes chatting with you, right? If they're able to talk. And typically you can hear it in their voice. They'll tell you, right? So if you just sit behind them and you're on the computer, you're not going to have that same opportunity. So be engaged in the patient care that you're providing. Our stable patients, so that not sick, we're reassessing. I like to do every 10 minutes. On longer transports, maybe I'll bump it up to 15. Um, but historically, you're going to hear 5 and 15 minutes is the unstable and stable. So 5 and 15 minutes are the common numbers there. So we're going to be reassessing our primary assessment. So that's the mentation, our A's, our B's, our C's, priority. If you get a patient and they're low priority at the beginning, and you get through and you're like, ooh, that's not good, bump them up, right? You can be mid-transport and change the priority of the patient, right? Don't be afraid of doing that. Recheck your vitals. Recheck all of the vitals that you did. Typically, we don't reassess blood sugar unless we've either done an intervention that would change the blood sugar or their mentation changes or something like that. So, you know, we're not necessarily rechecking every vital, but a lot of the common ones. And make sure you're rechecking your interventions. If you did something recheck it. Is it still working? You don't have to undo it and redo it. Um, but if you put a tourniquet on to stop bleeding, is the bleeding still stopped, right? Last thing you want is the patient to bleed out in front of you. So make sure that you're rechecking your interventions.